implementation of nursing care model in post-stroke urinary incontinence patient. Urinary incontinence is sequelae of stroke. Prevalence of post-stroke urinary incontinence is about 32% to 79%. 25 to 28% urinary incontinence occur after discharge from the hospital, and 35 to 40% occur 7 to 10 days after acute stroke. The epidemiology of urinary incontinence in Indonesia is not clearly recorded and still taboo things. Continence care in hospital tends to focus on continental product and more focus on addressing physical problems. Until now, there is no research in Indonesia that maintains continence in the patient home. There were 3 stages of model development, namely, the first stage was a qualitative research in the form of a case study with a total 18 informants. Then enter the second stage, namely model development. At this stage, an intervention model was developed based on literature study and qualitative research results. At this stage, an expert consultation was also carried out. The third stage was model trial using quantitative research method, namely non-equivalent control group pre-test, post-test design on 56 respondents. Model trial on the patient quality of life. This trial-based research was carried out for 8 weeks with 3 measurements: pre-test, post-test, and after post-test. This research was conducted in Indonesia, Southeast Sulawesi. The result of the first phase of the research were that 5 terms were obtained through a thematic analysis process. These terms were: the first term is information and understanding of post-stroke urinary incontinence. Second term is doing ways to deal with post-stroke urinary incontinence. Third term is self-control and staying motivated. Fourth term is carry out activity independently according to ability. And fifth term is family support and peer attention. On the model development stage, integrating the terms found into the theory of human becoming and self-care deficit theory of nursing, where terms 1, 2, 3 were part of the theory of human becoming, and terms 1, 4, 5 were part of the theory of self-care deficit theory of nursing. Based on the schematic model chart, we can see that the patient independence in overcoming post-stroke urinary incontinence is the core of the problem regarding the need for information and understanding of post-stroke urinary incontinence, ways to overcome post-stroke urinary incontinence, self-control and staying motivated, performing daily activity independently according to ability, and family and community support include friends' attention. In the implementation of models, there were 5 activities, namely health education, skill training, assistance by researchers, monitoring, and the last activity is follow-up. In the first activity is health education carried out in the first week of the model implementation phase and carried out in the nursing ward in hospital. Second activity is skill training, carried out after health education in the first week to the second week. This activity is carried out when the patient condition in the recovery stage and is ready to return home, so that the implementation is in the ward and then continue at the patient home. Activity third is assistance by researcher, assisting in the implementation of clinical skills that have been taught to patients, such as bladder retraining exercise, pelvic floor muscular exercise, distraction technique exercise, and positive thinking. This assistance is carried out in the third week at the patient home through home visit. And for activity is monitoring, monitoring the implementation of intervention that have been taught to patient is carried out through home visit and by telephone. This is done in the fourth week. And the last activity is follow-up. Follow-up was carried out in the eighth week. Demographic data at the model trial stage can be seen from this chart. The average of or mean age in the intervention group was 56 years old, while in the control group was 54 years old. Most data on sex in both groups were female. The latest education data in the intervention group was that the most graduates were undergraduates, while in the control group were the most high school graduates. The two groups most often experience left hemiparesis or paralysis on the left side of the body. Both groups experience of most mixed urinary incontinence, and both groups experience the most severe degree of urinary incontinence, and both group mostly merit status. In the table, it can be seen that the measurements were carried out 3 times. In the first measurement, there is no relationship between the implementation of the model and the patient quality of life. A significant relationship can be seen in second and third measurement. In the graph, we can see that there was an increase in the average score of quality of life in the second and third measurement in both groups, but a significant increase was found in the intervention group. This increase is related to the effectiveness of the intervention contained in the model. Another study say that patients' quality of life score was significantly higher in patients with mild urinary incontinence compared with severe urinary incontinence. This can be attributed to the implementation of this model focusing on improving the individual's ability to manage post-stroke urinary incontinence independently, actively participate. Positive thinking can be used to improve the quality of life. Social and emotional support is important for quality of life. High level of social support is associated with better mental health. This model can be integrated in nursing care, and increasing patient satisfaction with this model, increasing patient independently. This research can continue to be developed by adding variables that need to be researched. Thank you. That is all my presentation. I return to moderator. Thank you.
Thank you, Dr. Heltty, for